esophagus is a fibromuscular tube, approximately 25 centimeters, that is 10-inch in length, that transports food from the pharynx to the stomach. It originates at the inferior border of the cricoid cartilage, that is at the level of C6, and extends to the cardiac orifice of the stomach, that is at T11. Now, this is the esophagus colored with yellow paints, and this is the pharynx. This is the oropharynx, and this is the nasopharynx. So the esophagus commences from the pharynx and ends at the cardiac orifice of the stomach, which is at the level of T11. You should know cardiac orifice is at T11. You shouldn't confuse this with the esophageal hiatus. How the esophagus enters the diaphragm at the level of T10. And the level of its commencement at the level of C6. So these extents are important for you to pay attention. And the true length of it is 25 centimeters or 10 inches. However, in some questions, this length of the esophagus is described in relation to some fixed anatomical positions, which we will see. Now, this image is showing us the position of commencement of the esophagus. It commences from the pharynx, okay? This, just below the pharynx, you have the larynx here. So you have the nasopharynx, the oropharynx, and the larynx is here. And you have the esophagus commencing from the level of the cricoid cartilage, which is denoted here at the level of C6. Now, the esophagus is described, its length is described in relation to some fixed anatomical structures, especially in your exams, where you see questions relating to the length of the esophagus measured from the tip of the incisor teeth. And if you notice, from the tip of the incisors to the commencement of this esophagus is about 15 centimeters. So whatsoever you are measuring, you are adding 15 cm to this length. Okay. Now you can see, if you are talking about this length from the tip of the incisors to the esophageal hiatus, now you'll be talking about 40 centimeters now. Okay, so you should take note of the anatomical landmark that is being mentioned in the question. When you see the cricoid cartilage up to the esophageal hiatus, you are talking about 25 centimeters. Now, it runs its course in both the cervical portion and the thoracic, as well as the abdominal part. The esophagus has its cervical portion, the thoracic portion, and the abdominal portion. Its course in the neck, it commences in the median plane, and is slight deviation to the left, okay, at the thoracic inlet. So its commencement is initially at the midline with a slight deviation to the left as it approaches the thoracic inlet. The trachea and the thyroid gland are immediate anterior relations. So you should know these important anatomical structures that are in front of it, the trachea, as well as the thyroid gland. And you will see some of its blood supply, for example, is by a branch that supplies both the thyroid gland as well as some part of the esophagus, the inferior thyroid artery, because of this close anatomical relation. Now, the sixth and seventh cervical vertebra and the prevertebral fascia are behind it. So, the cervical portion posteriorly has the sixth and seventh cervical vertebra as well as the prevertebral fascia, forming a posterior relation of the cervical esophagus. On either side, it is related to common carotid arteries and the recurrent laryngeal nerve. And this recurrent laryngeal nerve, okay, falls in the groove that is between the esophagus and the trachea. There's a groove that is between the esophagus and the trachea, and this recurrent laryngeal nerve lies in that groove. And you can see it's a lateral relation of the esophagus. On the left side, it is also related to the subclavian artery and terminal part of the thoracic duct. Now, always remember that this thoracic duct crosses to the left side, okay, at the level of the sternal angle, and it empties at the left side at the junction of the subclavian and the internal jugular vein. And if you notice, because it drains lymphatics from the lower part of the body, the abdominal cavity, and so on, malignancies that are drained from this lower portion can be deposited at the junction of the entrance of this thoracic duct into the venous system, and they may form a nodule there. I believe you've heard of the varicose node. Okay, this is left supraclavicular enlargement from the position of malignancy at the entrance of the thoracic duct. So don't forget, the thoracic duct crosses to the left side, okay? And of course, it forms a left relation of the esophagus. Later, someone will tell me the sign when you see the varicose node. What is that sign called? Now, the thoracic relation of the esophagus. The thoracic part traverses first the superior and then the posterior mediastinum. From the superior mediastinum, it enters the posterior mediastinum. So from superior to posterior. We'll discuss this when talking about thorax, God willing. From being somewhat over to the left, it turns to the midline at T5, then passes downward. So if you can imagine its course, it initially started at the midline. It moves, okay, to the left, and the course returns to the midline at the level of T5. Then it passes downwards and forward. Okay, you can see the course, how it deviates. Okay, now, and to the left to reach the esophageal opening of the diaphragm at the level of T10. Don't forget esophageal opening. The diaphragm is at the level of T10, while the cardiac orifice, where the esophagus meets at the cardiac junction, is just T11. Now, it's important you understand the structure of the esophagus. We describe it as a fibromuscular structure, and its peculiar anatomy gives it some important clinical correlation we'll see shortly. The esophagus share a similar structure with many of the organs in the alimentary tract. The outermost covering is by a loose areolar tissue known as the adventitia. This is unlike other parts of the intestine that is covered by the serosa. Okay? Note, the very distal and the intraperitoneal portion of the esophagus has an outer covering of the serosa instead of the adventitia. Now, lack of serosa in the esophagus makes the spread of malignancy rapidly to adjacent structure, unlike other parts of the bowel where you have subserosal deposition before it bridges, going beyond the serosa, then entering the peritoneum, having a peritoneal seedling and deposit. But for esophagus, it lacks that serosal covering. Now, the muscular layer, the external layer of the longitudinal muscle and the internal layer of the circular muscle. Which one is external? The longitudinal muscle, and the inner circular muscle. Now, you should know that the external layer is composed of 3 different muscle types in each third. The upper 1/3 has voluntary striated muscle. The middle third has voluntary striated and smooth muscle. So the middle third is mixed of both striated and smooth muscle, while the lower third has only smooth muscle. Okay? Then the next layer is the submucosa, and these submucosal layer contain mucous gland. Okay, a lot of secretory mucous gland. Now, the mucosa, what is the epithelium? Epithelial lining of the mucosa. It's made from a non-keratinized stratified squamous epithelium that is continuous with columnar epithelium of the stomach. Okay, so food is transported through the esophagus by peristalsis, which is a rhythmic contractions of the muscles which propagate down the esophagus. Hardening of this muscular layer can interfere with peristalsis and cause dysphagia. So it's important to have a regular and a well-coordinated contraction of the esophagus for a smooth peristalsis. Any interference will cause difficulty in swallowing. So this is just a pictorial representation of the layers. We said it has adventitia, not serosa, don't forget. unlike other parts of the intestine that is covered with serosa. But the abdominal portion of the esophagus is the part that is covered with serosa. The adventitia is a loose areolar tissue. A lack of serosa make malignancy easily spread to adjacent structure. Okay. But with serosa, you know it's going to limit the immediate spread until it bridges the serosa. It's now deposited in the peritoneal cavity. This is very important, you know. Then we talked about the muscular layer that has an outer longitudinal muscle that has striated muscle in the upper third, okay, mixed striated and smooth muscle in the middle third, and smooth muscle in the lower third. Then you have inner circular muscles. Then you have the submucosa and the mucosa that we said has a lot of the submucosa has a lot of mucous gland, okay, and then the what do you call it, non-keratinized stratified squamous epithelium that is continuous with the columnar epithelium. So you should be aware that there are two sphincters of the esophagus, which the upper one is the true anatomical sphincter, while the lower sphincter is just a physiologic sphincter. It doesn't have an anatomical sphincter. It's just physiologic. There are two sphincters present in the esophagus, known as the upper and lower esophageal sphincters. They act to prevent the entry of air and reflux of gastric content, respectively. Now, the upper esophageal sphincter. The upper sphincter is an anatomical striated muscle sphincter at the junction between the pharynx and the esophagus. It is produced by the cricopharyngeus muscle. So this muscle gives rise to the upper esophageal sphincter, and remember, is a true anatomical sphincter. Normally, it is constricted to prevent the entrance of air into the esophagus. Now, the lower esophageal sphincter. The lower esophageal sphincter is located at the gastroesophageal junction, and it's physiological or functional sphincter, as it does not have any specific sphincteric muscle. What is the muscle that gives rise to the upper esophageal sphincter? The cricopharyngeus muscle. Which muscle gives rise to the lower esophageal sphincter? No any specific muscle. So what gives the sphincter is just the folds at that junction. The gastroesophageal junction is situated at the level of T11 vertebra, and it is marked by the change from esophageal to gastric mucosa. The moment you cross the esophageal mucosa, to identify a gastric mucosa, you will see a lot of rugae. It is the rugae that tells you that now you are in the stomach. When you are doing an upper GI endoscopy, okay, when you just enter the stomach, you will see a change in the appearance. You see a lot of rugae, which signifies that you are in the stomach. The sphincter The lower sphincter, as we talked about, is a physiologic or functional sphincter. It does not have any specific, sphincteric muscles. Instead, the sphincter is maintained by 4 factors. What are these factors? The esophagus enters the stomach at an acute angle. Okay, the walls of the intra-abdominal section of the esophagus are compressed when there is a positive intra-abdominal pressure. Prominent mucosal folds at the gastroesophageal junction aid in the occluding the lumen. Okay? The right cross of the diaphragm has a pinch-cock effect on that sphincter or the region. So these 4 factors gives the lower esophagus its sphincteric action rather than having a true anatomical muscle that confers the sphincteric action. During esophageal peristalsis, the sphincter is relaxed to allow food to enter the stomach. Otherwise, at rest, the function of this sphincter is to prevent reflux of gastric acid content into the esophagus. Okay, so when there is the sphincter down there loses its competency, all these 4 mechanisms are not taking a proper effect. There is reflux, okay, or when the length of the abdominal portion is abnormally lengthy, they may have this risk. Now, there are some important anatomical relations of the esophagus. The anatomical relations of the esophagus give rise to 4 physiological constrictions in its lumen. It is these areas where food or foreign body or foreign objects are most likely to become impacted. Usually, when a foreign body is swallowed and it goes beyond the esophagus, okay? It goes beyond the cricopharyngeus, that narrowing, okay? It's likely to be passed out. It's unlikely to get impacted because that is the narrowest portion of the gastrointestinal tract. So once a child swallows a foreign body and you do X-ray and you see the foreign body in the stomach, so it's unlikely to get impacted because it has passed the narrowest portion of the gastrointestinal tract. Now, these constrictions are remembered using the acronym ABCD. The arch of the aorta gives esophageal constriction, left main bronchus, cricoid cartilage, diaphragmatic hiatus. These are 4 constrictions that are caused by some anatomical relations, okay? And these constrictions lead to likelihood of impaction of foreign body. Now, sometimes in your multiple choice questions, you will just see the following structures are posterior relations of the esophagus, anterior relations of the esophagus, or the abdominal esophagus. So this table is very important. Look at the cervical and thoracic as well as the abdominal. What are the anterior relations? of the cervical and the thoracic, as we mentioned. Trachea, left recurrent laryngeal nerve, pericardium are anterior relations of cervical and thoracic esophagus. Posterior relation, thoracic vertebral body, we mentioned from what level to what level. If you remember, the thoracic duct, azygos vein, descending aorta. On the right, pleura, terminal part of the azygos vein, left subclavian artery. On the left, aortic arch, thoracic duct, as well as the pleura. Abdominal relation, anterior, left vagus nerve, posterior surface of the heart. Posterior relation of the abdominal esophagus, right vagus nerve, left cross of the diaphragm. So some of these you need to have a mental picture of some important relations, okay? Especially vagus nerve is very important, as well as positions of the recurrent laryngeal nerves. What is the vasculature of the esophagus? In respect to its arterial and venous supply, the esophagus can be divided into a thoracic and abdominal component. The thoracic component. The thoracic part of the esophagus receives its arterial supply from the branches of the thoracic aorta and the inferior thyroid artery, a branch of the thyrocervical trunk. Thyrocervical trunk is a branch of the first part of the subclavian artery. Now you can see in the thoracic part, okay, branches from the thoracic aorta directly supplies the esophagus, as well as branches from inferior thyroid artery, which is also supply the thyroid gland, which is one of the anterior relations of the esophagus. Venous drainage into the systemic circulation occur via branches of the azygos vein and the inferior thyroid vein. Now, abdominal esophagus. The abdominal esophagus is supplied by the left gastric artery, a branch of the celiac trunk. The celiac trunk is one of the anterior branches of the abdominal aorta. And the celiac trunk has three branches. The left gastric artery that supplies the lesser curvature, as well as the abdominal portion of the esophagus. It has the splenic artery and the hepatic artery, common hepatic artery. Now, remember, the abdominal portion is supplied by left gastric artery, a branch of the celiac trunk, as well as left inferior phrenic artery. This part of the esophagus has a mixed venous drainage via two routes. So the portal circulation via left gastric vein, to the systemic circulation via azygos vein. This is also a relevant anatomical position because these two routes form a portosystemic anastomosis and a connection between the portal and systemic venous system. When there is a rise of portal pressure, beyond 12 millimeters of mercury will become significant, and patient will have portal hypertension. And portal hypertension manifests with engorgement of sites of photosystemic shunt. And this is one of the sites at the esophagus. And of course, they can rupture and present with upper GI bleeding, which is massive. This picture is showing us branches. Okay, this is the esophagus. Okay, this is the inferior thyroid artery, a branch of the thyrocervical trunk. Okay, this is the subclavian artery. This is the aorta. You have thoracic and esophageal. You have thoracic, aorta, and the esophageal branches. Okay, this shows the zygous vein. The innervation of the esophagus, you should know they have both autonomic and via the sympathetic, parasympathetic, the sympathetic trunk. The esophagus is innervated by esophageal plexus, which is formed by a combination of parasympathetic trunk and sympathetic fibers from cervical and thoracic sympathetic trunks. So they get fibers from both the sympathetic, okay, chain as well as the parasympathetic vagal trunk. You know, the vagus to the esophagus is what? Parasympathetic. Now the vagus plexus gets combination of parasympathetic coming from the vagus and sympathetic coming from the thoracic and cervical and sympathetic trunks. So from the plexus, they supply the esophagus. The vagus is parasympathetic, has two different types of nerve fibers that runs in the vagal trunk. The upper esophageal sphincter, okay, and upper striated muscle is supplied by fibers originating from the nucleus ambiguous, while the fibers supplying the lower esophageal sphincter and smooth muscle of the lower esophagus arise from the dorsal motor nucleus. The lymphatics. The lymphatic drainage of the esophagus is divided into three. The superior third drain into the deep cervical lymph nodes. The middle third, superior and posterior mediastinal nodes. And the lower third, left gastric and celiac nodes. You can see malignancies of esophagus can be so devastating. They will involve both the supra portion of lymph nodes above and below the diaphragm. Okay, because you can see from the neck, deep cervical lymph node will be involved. Mediastinal lymph node, both the superior and the posterior mediastinal in the chest will be involved, as well as the abdomen, because it has abdominal portion. And of course, all the drainage of the stomach eventually drain to the celiac group of lymph node. And because they have the same supply, the left gastric artery that is arising from the celiac trunk, and the lymphatics run along these arteries, they drain to that end point. Radiologically, the esophagus is studied by X-ray taken after a barium swallow. You know, when you are doing a barium study, barium series, barium swallow outlines the esophagus. Barium meal outline the stomach. Follow through. Small intestine. And enema. Large intestine. So anytime you are outlining the esophagus using a barium study, you call it barium swallow. Okay, and when the patient takes in barium, an X-ray is taken of the chest, which will show the contrast outlining the esophagus. Okay, so the esophagus is studied by X-ray taken after a barium swallow, in which it is seen lying in the retrocardiac space just in front of the vertebral column. That is when you do a lateral view. That is when you appreciate this description. Anteriorly, the normal esophagus is indented from above downward by three most important structures that cross it. Now you see on that barium, you can see this important constriction where it is compressed by the arc of the aorta, the left bronchus, and the left atrium. Now, for esophagoscopy, measurements are made from the upper incisor teeth. The three important levels are 7-inch, 17 cm, 11-inch, 28 cm, and 17, 43 cm, corresponding to the commencement of the esophagus. Commencement is at 17 cm. Okay, the point at which it is crossed by the left bronchus, okay, and its termination, respectively, that is at least 43 cm. These 3 points are also indicate the narrowest part of the esophagus. The site at which, as might be expected, a swallowed foreign body are most likely to become impacted and strictures to occur after swallowing corrosives. Now, what corrosives? Somebody should tell me what corrosives cause esophageal stricture and why. At the end of the lecture, someone should volunteer to tell us what corrosive and why esophageal stricture. The anastomosis between esophagus, which is systemic, and the left gastric, which is portal venous tributaries in the esophageal vein, is of great importance. In portal hypertension, which we mentioned earlier, these veins distend into large collateral channels, esophageal varices, which may then rupture with severe hemorrhage, probably as a result of peptic ulceration of an underlying mucosa. We talked about upper GI bleeding coming from esophageal varices. Okay. Now, use is made of the close relationship between the esophagus and the left atrium in determining the degree of left atrial enlargement in mitral stenosis. In mitral stenosis, you have enlargement of the atrium, and because the atrium is indenting on the esophagus, when you do a barium swallow, it will show a marked backward displacement of the esophagus caused by the dilated atrium. The esophagus is crossed solely by the vena esophagus on the right side. This is therefore a site of election to approach the esophagus surgically. So this is where we are going to stop. Then I will entertain questions, comments, and contributions. So you can all unmute yourself, and if you have any question, you can ask. Thank you very much. Yes, any? Any question?
Yes, thank you very much, sir. I have a question. Like,
You can go ahead.
regarding, okay, the measurement from the incisor, it says from the incisor to the gastric opening, the cardiac opening of the esophagus into the stomach is 40 cm. But at the end, when you were explaining, there was a place where they said 43 cm. Is it a range like 40 to 43, or are they two different measurements?
Yes. Usually the range is 40 to 45 cm.
Okay.
You will see in the text, some text will say 45 cm, some will mention 43 cm, but usually the range is from 40 to 45. If you will know the distance in your own, of course, and that of Dr. Sadiq, maybe you have a difference of 2 centimeters. So I know Dr. Sadiq will not doubt that.
The Kazoo has longer one. Mine will be shorter.
Yes, any other question? Yes, I saw Dr. Abdullah throw a question that gastric cancer is where we see virtuous node. That is not the question I asked. I say, what is the name of the sign?
It's Trosia sign.
Trosia sign, yes. Trosia sign. How do you spell it, Dr. Sadiq?
Troisier and then apostrophe S. Troisier apostrophe S sign.
Do you agree with this spelling? Dr. Abdullah?
Yes, we agree, sir.
So how does it differ from Trosia sign?
And we see the other one in hypocalcemia.
Yeah. Yes. Let's go back to the second question. I asked another question.
Yes, regarding which type of corrosive will cause stricture?
Yeah. Said alkali corrosive will cause stricture. Why? Yes, you get the answer right. It's alkali that causes corrosive post-radial stricture. Yes, can anybody help us with the reason?
Does it have to do with the type of necrosis you have in acid and alkali?
Are you
In
asking
alkali, you have
or you are answering?
in alkali you have liquefactive type of necrosis. So it actually, and in acid we have coagulative. So when the cells become coagulated, they prevent the acid from actually penetrating deeper.
You are right. You know, liquefactive necrosis penetrates. It penetrates the depths of the wall. When it is hidden by fibrosis, it will cause narrowing, while coagulative necrosis will cause scab formation of the mucosal layer, coagulating it, and more of the acid will now go down, preventing it from penetrating the wall of the esophagus. More of it will cause damage in the stomach than the esophagus. Yes? Did that raise any other question? Any other question? So sorry, because of the excuse I gave earlier, we are going to stop here. But tomorrow we have a class because we need to finish all the gastrointestinal structure so that we might even add more classes subsequently so that we'll start discussing other aspects. So thank you very much. We are going to stop here.
Get well soon, sir.
Thank you.
Thank you.
Okay, thank you. I'll answer.
Okay.